Morning, Mr. Johnson. I'm Dr. Kemp. How are you?
Good morning, Dr. Kemp. How are you?
Good.
I've been having a problem recently with
Okay.
my fingers. Well, it started with my fingers, where I've had this weird tingling sensation in them.
Okay.
And after that, it's progressed to my upper arm, where I'm starting to feel weakness in it, if that makes sense.
Okay.
Some days I have trouble breathing. Some days I have trouble swallowing. Some days I have trouble speaking with people. And every once in a while, I also get kind of a weird, weird spasms in my arms, and they start feeling really weak.
Yeah. So you would definitely say that it's progressing towards your core.
Right, it's going toward, yeah, right.
Definitely. I think that it may be some of the effects of a neurological disorder. I'm actually going to go grab one of our specialists, and we'll come back and maybe discuss some options with you.
Thank you, doctor.
Great.
Dr. Kemp?
Mr. Johnson.
Mr. Johnson, I'm Dr. Roberts.
Hello.
Nice to meet you. Okay, so Dr. Kemp and I have discussed some of the symptoms that you were explaining to him, and we believe that they correlate with early signs of ALS.
What is ALS?
Well, let's talk about what ALS actually is and some of your options going forward.
All right, thank you.
So amyotrophic lateral sclerosis is also known as ALS. You may more commonly hear it referred to as Lou Gehrig's disease, due to the famous baseball player who had the disease in the early 1900s. ALS is characterized as a degeneration of both upper and lower motor neurons, leading to progressive muscular paralysis and eventually death. In your personal case, you discussed how you began with a loss of feeling in your fingers that seemed to progress up your arm, and now you're experiencing speech deficits. These slurs in your writing and speech are typically seen in patients with early onset ALS. It appears that you have progressed through the initial onset phase, meaning that these progressive deterioration aspects will continue until virtually all voluntary muscles are affected.
ALS is thought to begin by degrading your motor neurons. The specific motor neuron affected is the alpha motor neuron. In the spinal cord, motor neurons are grouped in columns called motor neuron pools. In each of these pools, all the motor neurons innervate a single muscle. For every muscle, there is one motor neuron pool. ALS seems to affect the lower alpha motor neurons in the ventral horn of the spinal cord, the prefrontal motor neurons, and the corticospinal upper motor neurons in the precentral gyrus. Current research also indicates that proprioceptive sensory neurons could actually also be an early signal of onset.
The primary motor cortex, premotor cortex, and supplementary motor area collectively make up the motor cortex, which plans voluntary actions, coordinates sequences of movements, makes decisions, and gives commands to the lower motor neurons in order to carry out the desired movement. Anatomically, the motor cortex is located in the frontal lobe, which is just anterior to the central sulcus. The primary motor cortex is located in the precentral gyrus and on the anterior paracentral lobule on the medial surface of the brain. Stimulation in this area of the motor cortex results in movement of individual body parts. Voluntary movements come from motor commands driven by the corticospinal system, which enables higher level processing from the cortex to reach the muscles that the cortical region wants to contract. The corticospinal tract is the only descending pathway that has direct innervation on alpha motor neurons. This allows the cortex to control fine movements of the fingers and hands with great precision and accuracy. If the corticospinal tract is damaged, as seen in ALS, there is a permanent loss of fine motor skills and control of the extremities. However, possibly, there could be coarse movements that could be preserved if parallel pathways remain intact.
Amyotrophy refers to the atrophy or wasting away of muscle fibers. These muscle fibers are denervated as their corresponding ventral horn cells deteriorate. Lateral sclerosis occurs when the anterior and lateral columns of the spinal cord harden and the motor neurons deteriorate and they get replaced by fibrous astrocytes. Due to the death of the ventral horn, the motor neurons that reside in that spinal segment break down.
Schwann cells will then catabolize the axon's myelin sheath and break it into fragments after engulfing it. Macrophages are recruited to the area in order to clean up the debris, so they will phagocytize the small compartments formed from the fragments. Often this kind of axonal degeneration can be seen in the corticospinal tracts on the biopsy of the brain. If ALS had been present for a significant amount of time, atrophy of the primary and premotor cortices may have also been seen. Doing a biopsy on the spinal cord can also show atrophy of the ventral horn as well. Some motor neurons in the brainstem and spinal cord are actually typically unaffected by ALS. The oculomotor, trochlear, and abducting cranial nerves in the brainstem are preserved, as well as the posterior columns, spinocerebellar tract, nucleus of Onoff, and Clark's column. Your chart doesn't indicate any family members that have had ALS. This could be a sign that you have sporadic ALS. However, we still want to take some genetic tests to determine whether you have familial ALS, which accounts for 7% of all ALS cases. 20% of familial ALS cases are related to a mutation of the gene that produces the superoxide dismutase 1, SOD1, enzyme. This enzyme is thought to provide nuclear protection, which is required to block free radical-induced DNA damage. Free radicals are produced normally by cells through metabolism. They are highly reactive and must be neutralized, or else they can accumulate and cause damage to the DNA and proteins within cells. Over 170 mutations in the SOD1 gene have been shown to cause ALS. Most of these mutations occur by a change in one of the amino acids in the SOD enzyme.
Other possible causes of cell death include oxidative damage, mitochondrial dysfunction, apoptosis, defects in axonal transport, growth factor expression, glial cell pathology, and glutamate excitotoxicity. Glutamate excitotoxicity was found in sporadic disease and led to the only approved treatment, riluzole.
Mr. Johnson, your test results indicate that you do not have a mutation in any of the genes known to cause ALS. This means that you do not have familial ALS, however you have sporadic ALS, which is what 93% of patients do have. We're going to go ahead and start you on a riluzole treatment. This is a preemptive move to negate deterioration before it progresses to your diaphragm, which occurs over time as it progresses from your skeletal muscles towards your core. Riluzole is not a cure, however, it is a treatment. It is known to extend life about 3 to 5 months on average in patients, depending on where you are in the progression of your disease individually. ALS is more prevalent in males around age 55. It affects 5,600 new patients in the United States every year. In the United States, about 30,000 patients have it at one time.
Is there anything else I can do apart from taking the treatment?
Well, for right now, we would require you to start walking a mile a day to mitigate the effects of ALS and by maximizing the muscle function and locomotion. For some future options, you can do physical therapy, the use of a wheelchair, or rehab.
We'd also like to see you every 2 weeks for a bi-weekly assessment. So thank you for coming in today.
Thank you, doctor. Thank you, doctor.